The patient is an 80-year-old male who initially presented with acute aortic syndrome and was noted to have a type B intramural hematoma. He was initially managed non-operatively. On subsequent follow-up visits, repeat scan showed interval development of a penetrating aortic ulcer in the distal thoracic aortic arch. Thus, we took the patient for a thoracic branch device implantation. Fusion marks were obtained using preoperative CT showing the left subclavian origin and the bovine origin of the left common carotid and brachiocephalic arteries. Femoral access is obtained, and at this point we have a Lundquist wire in the arch and the left subclavian artery is cannulated with another wire and advanced as distal as possible in the arm for more wire support. The device is then flushed with CO2 as seen here. The primary and branch wires are then inserted into the device to be able to advance it through our axis to its appropriate position. The device is then partially advanced into the groin sheath, allowing back bleeding through the endoprosthesis to flush the graft and avoid any air emboli during eventual deployment. The device is then advanced over the wires and its tip is parked near the expected level of deployment based on the generated fusion marks. A marker pigtail is then advanced over a wire and an arch aortogram is obtained. The main device is then positioned appropriately, taking care not to cover the bovine origin and deployed as seen in this portion of the video. Of note, TCD monitoring shows evidence of bihemispheric embolization during deployment of the device, as seen here on the TCD monitoring tracing. We then attempted to advance the left subclavian artery branch device, however it kept catching on the gate and resistance was met. It is important here to avoid pushing the main body forward as one is trying to advance the branch device. Therefore, we obtained access into the left brachial artery and snared the wire to secure through and through access for more wire support. Tensioning the wire from both ends and using the help of a long 6 French sheath introduced via brachial axis, and then advance its tip through the gate and advance the cone of the branch stent graft into the long 6 French sheath tip, and pulled both back into the proximal left subclavian artery, and then deployed the branch stent graft, taking care not to cover the left vertebral artery. We then performed angioplasty of the left subclavian artery branch graft, and an interesting observation was noted on TCD monitoring, showing compromised flow in the left common carotid, temporarily secondary to compression by the balloon, since the left common carotid courses posteriorly to the left subclavian artery in this patient. We then performed a repeat aortogram with appropriate positioning of the stent grafts, with good seal and no endoleaks were noted, as well as preserved flow into the left common and left vertebral arteries. Additionally, a 3D cone beam CT was performed intraoperatively to rule out any compression of the left subclavian stent graft, as well as visualize the relation to the gate or portal. Additionally, we can see good opposition of the main body in relation to the inner curve of the aortic arch. Lastly, few lessons and conclusions to highlight. Thoracic branch grafts are likely to be the primary interventional therapy for complicated acute type B syndromes. Multiple techniques are demonstrated on how one can facilitate gate cannulation. Early upper extremity access facilitates gate cannulation. TCD monitoring helps identify the embologenic phases of the procedure. Completion cone beam CT helps identify if there is any stent compression. Lastly, techniques for air removal from the device were illustrated as well.